Welcome everybody. We have a great panel here. We have Dr. Harsh Mahajan Shri, as well as a leading entrepreneur in the radiology space. You all know him. We have Mr. Rupam Choudary, who is the Global Head of Engineering in Healthcare and Life Sciences with TCS. We have Dr. Vipin Tyagi, who is the leading surgeon in kidney and robotics with Ganga Hospital. And we have Nanki Lakhwinder Singh, Ms. Nanki Lakhwinder Singh, who is the owner of FATEH Seniors Care. Welcome everybody. We'll try to raise the caliber of the dialogue, but it's a very high caliber panel. We will try to divide this discussion in diagnostics, therapeutic, which is surgery, and care or rehabilitative plus care. Let me start with Dr. Mahajan by asking him, Dr. Mahajan, what do you think is the contribution of AI in diagnostics? How is it changing diagnostics?
Thank you very much, Pavan, and thank you, BW Health World, for inviting me here. Now, diagnostics and specifically radiology and imaging has been the one field in healthcare maximally impacted at the early stage. Today, there are over 1,000 US FDA approved AI algorithms that are in use in imaging. And we've been involved at Mahajan Imaging and Labs in AI since the last 8 years. Now, if we look at the continuum of care in radiology, it starts from the patient coming in and getting scanned, then the technician looking at the images, followed by the radiologist, measurements being done, lesion being identified, and finally the holy grail, which is the radiologist writing the report. In all three, there is contribution of AI. First, most of the new MRI CT scanners that are coming today have AI reconstruction inbuilt. So if we talk of MRI, if a scan was taking half an hour to do, with the use of AI, you can actually hasten the scan and do it in 15 minutes or 10 minutes, or you can use the same 30 minutes or 25 minutes and get a much higher quality of scan because of AI reconstruction that is within. So you can improve quality, at the same time you can improve productivity, the numbers that you're able to scan, and for the patient it is better because they are able to do the scan much quicker, and it's that much lesser time in the magnet. Now if we talk of CT, there with much lesser radiation dose, you're able to get diagnostic quality scans. Noisy images, if we were not to use AI, but they become diagnostic, good quality, pristine images if you use them. So similarly in other fields. Then we come to automatic measurements, volumes, all of that, lesion identification, and then measurement of the lesion. This also is something that is, there increasingly in the newer machines that are coming. And so the machine itself, the computer within the machine will recognize the lesion and will tell you, that so many nodules in the lung are there, and this is the size of each of them, or lesions in the brain or elsewhere in the body. So that makes the task of the radiologist much easier, especially when we are looking at, metastatic disease in the lungs, and there are 50 nodules. It's able to automatically, for a radiologist, it's futile trying to measure. It may take half an hour, whereas here it's done in a matter of a few seconds. And so lesion identification, measurement, even comparisons. When you do a follow-up scan to know that it has become larger, it was 3 centimeters, it's now 5, all that done automatically. So working as a radiologist assistant. Then we come to the holy grail, like I said, which is making the diagnosis itself. There are algorithms available today for chest X-ray, chest CT, brain CT, brain MRI, the fracture detection, which will actually identify the lesion and also write a report as if a human radiologist has done it. And this is increasing. Till now, there is only one AI algorithm for chest X-ray that has been given, that has been CE marked for autonomous reporting. Otherwise, most AI algorithms are still helping the radiologist. Is the radiologist who's taking the onus, saying, I agree with this, I don't agree with this, and so on and so forth. Now, in the radiology department, ultimately 250, 300, 400 algorithms will be used. They will come from 150 different developers. How does a hospital use them? How does a hospital even come to know about them and acquire them? They are not going to talk to 150 different companies or startups. So that's where we developed Carpool.ai, which is like a marketplace for AI. It's currently the biggest marketplace for AI in the world. It's like your Google Apps. And then to be able to deliver it in a seamless manner in an existing hospital information system or a PAC system that's existing. That's so Carpool.ai, I'm proud to say, is the one and only AI platform in the world which is US FDA approved and which is also CE marked, came from Defense Colony in Delhi, and currently in use at Harvard, Stanford, Thomas Jefferson, Emory, Yale, and many others across the world. So this is how AI is actually dramatically changing the way we do work.
Wonderful. So basically you said that the productivity, quality and safety of the scan itself is improving, whether it's a CT scan, X-ray, MRI. Secondly, the convenience for the radiologist is increasing and monitoring is also improving. And thirdly, the diagnosis is more precise. So really AI in the diagnosis space unequivocally is changing the landscape. Let me come to Dr. Vipin Tyagi. I'll go to the doctors first so that they can define what they are experiencing in this space before I go to the health tech and health tech entrepreneurs. Dr. Vipin, in your experience in robotic assisted surgery, how is it changing the space, and is your experience also similar to what Dr. Harsh said, or your experience is different?
Good morning to all, and thanks for this opportunity to sit among all the greats of the medical field. I'll just have 2 points, one about the robotic, another about the AI. Now we as a doctor, I always feel we are the best artist in the world available. Because when a physician is seeing a patient, he has to use his knowledge to the perfection. He cannot go back and read back. He may have to make a diagnosis. He should use all the 5 C's which are told by Dr. Narula. And he has to come to a diagnosis, start the treatment, monitor the treatment. But, and as a surgeon, we are also the artists. We have to perform a surgery with best of the dexterity, with best of the knowledge, again and again, and I cannot go back from the surgery. And painter can hold a painting and can go back and relax, but when I am doing a surgery, whatever type of it, I have to use all my skill to be perfect and to deliver the perfect. But we human beings are not the best creatures. We are not the best animal. We have the limitation of our vision. We have the limitation of our hand movements. We can hold our hand not for more than 30 seconds or 40 seconds without a tremor. So we have our limitations. And to overcome these limitations, we go back to the technology, and that's what the robotic surgery is giving us. It's giving us a 3-dimensional vision. It's giving us a dexterity which is correct to the minimal level. So it is basically augmenting my artistic skills to the level which I cannot do. This is what robotic surgery meant. And if I am perfect in my surgery, ultimately the gain will be of the patient and of the disease. Now regarding the AI, I always say, this is my concept, that in medical field the AI is of 2 types. One is dynamic, Another is static. Static means what? The diagnostic and radiology. You have an X-ray, you have data, you build an AI, and you build an algorithm and reach to a conclusion. But in a dynamic AI, like when I'm performing a surgery, I always say whenever I'm discussing it, that we all being in this world for years, but we have not seen two persons like each other. So the human body is not like each other. To generate something which is a dynamic AI, which actually change the surgical profile of any intervention, needs lots of data. So this dynamic AI concept is possible, but it will take time to be helpful to the mankind and to the health industry. And robotic surgery, we all say it is a new concept. No, it's not a new concept. It has been used since to the beginning of this new century, and it is a well-established treatment options. But we need to be choosy about when to use the robotic. So have to give a credit to the robotic surgery, not to give a discredit to a new intervention or a new technology.
Wonderful. So basically you are saying that robotic surgery is not new, it has been there for many years. That means, as you were sharing earlier, it is getting only slowly accepted. We will come to the reasons for that. What are the reasons for that? Why it is slowly accepted?
So one of the things, any technology which is coming into the field, the acceptance is held it back by the results. So once the result coming up, then the technology get accepted. One of the most prominent factor in India or elsewhere in the world is the cost. But I always say, when in 1996-97 mobiles comes, the incoming call is about 17 rupees. But when the technology advances, it's now decreasing to the level where anybody can use a mobile. So with the increasing competition in the robotic arena, surgery arena, the cost will come down. And lastly, sometime we use the robotic surgery in the field where it should not be used, according to me. Every technology is not meant for everything. Because if you use for a simpler cases, a robotic technology, it will do not have the advantage which we want to offer to the patient, or it can have a bad name. Doing a lap cholecystectomy or gallbladder surgery by a robot does not create any big future or any big thing. But doing a radical prostatectomy, which before 2000 is about 5% of cancer prostate patients are undergoing radical prostatectomy surgery. But now about 80% of the localized cancer prostate surgery patients are undergoing radical prostatectomy. So a technology should be used at a place where it matters. It's not for all.
Wonderful. I'm reminded that most medical technologies have hit some resistance in getting accepted. Even chloroform, for many, many years, women were not allowed to use chloroform during their surgery, during their pregnancy deliveries, because doctors said, or the society felt, doctors said that the soul, the soul which comes into the baby is will be interrupted. Till Queen Victoria said, nothing doing, I am going for my delivery, I want chloroform, forget the soul. And that's how we overcame that obstacle. And in test tube baby also, I was just thinking, as you said, test tube baby also, lot of people opposed test tube babies because they said, where will you get the soul from? Later on we realized soul is not required in that sense in the embryo for it to come alive. Very good points. The other point which you said, that some places it is being used extensively, for example in prostate cancer, because the advantage is very clear that the surrounding nerves will not be hurt. It will be a precise surgery of unwanted stuff. And in other surgeries, if it is used, sometimes it might get a bad name because it is overpriced at this time and might be seen as a frill, which is not adding much value. Let me come to my friend Rupam Choudary. What is your point on the dynamic and static point which Vipin said? He said that static, we are ready, and static AI is really working. But what is this dynamic AI which he is speaking about? Is there a whisper of a complaint there, or whisper of a suggestion there how robotics and AI should improve to be able to give the perioperative guidance which is not already stored somewhere, but perioperative? What is the purpose of that, why it is required?
Thank you so much. First of all, thank you everybody for having me among this august group of people. Dr. Mahajan obviously is the Mercedes, the Maybach class of diagnostics in the world. And Dr. Vipin obviously, the top-notch surgeon. Who am I actually? So since 1998, TCS has been engaged in healthcare, and we have seen the genesis of, first of all, digital radiography, digital templating. I am the guy who invented it. Then we went on to computer-assisted surgery, optical, as well as electromagnetics, and then we migrated into robotics, which is first, of course, which is prevalent now, which is your master-slave configuration. So today we run about a $5 billion business globally since the year 1998. And as of today, more than 2 million patients in the world have product inside of them that are designed by my teams. So I'm somewhat qualified to talk about the subject. And we have a team of full-time surgeons, orthopedic surgeons, cardiac surgeons, all other therapies, dentists even. We run almost 1,000 personalized dental designs every day based out of India. We use a lot of AI. One point I want to make before I come to the perioperative, guidance, which actually is a hint of a complaint, I know. So to your point, Dr. Mahajan, we see the use case of the ultimate output of a radiology. For example, if I'm going to use it for, let's say, UK-based company for a personalized knee, the quality of the radiograph, which is very important for downstream usage. So AI is being used to help your radiologist to ensure that the patient doesn't need to come back again. That first time right, you're getting the fit to purpose radiograph, which can be used downstream in AI. That's number one. To your point, we have faced ever since the early 2000s that as laparoscopic surgery is happening, there are a lot of issues. For example, maintaining the line of sight, because you can't expect a doctor to be, although doctors spend hours and hours, but it's a human deterrent to be able to fix it on the right tissue all the time. You locate a tissue because your cancer ovary removal you're doing, but you're bound to look elsewhere. Remember, old times used to look at the TV monitors, right? So things shift. So that's where AI comes in perioperative. We have designed system for our end customers, of course, which can warn the doctor that your line of vision is shifting, that you can actually now detect an area that you want to resect, and the AI helps you regain that location so that you are more confident that you are sticking to your planning. So that's the perioperative part. Also, when you're using this bipolar or devices for doing the anastomosis or tissue resection, here's an engineer sounding like a doctor. So you actually have smoke that comes out. So how can AI help you dehaze? So we have built algorithms that can dehaze the smoke so that you are not obstructed, so you're more confident. It doesn't replace your skill, but it makes you more efficacious so that the outcome is better. So that's the perioperative part. There is a host of now AI that is coming on the edge. Earlier, the preoperative planning part of a surgery used to be a big part of the platform that you would use. So you'd have the radiograph, you have the 3D reconstruction, and then you plan around it, right? Today, what is happening, the capability of NVIDIA boards, for example, or very high-tech computing can actually help you do it on the fly. So which means we are now working, for example, with the Tata Memorial Cancer Hospitals to help them build capabilities for maxillofacial reconstruction once the resection has been done. But as you said, Dr. Mahajan, that today it takes 4 to 5 weeks for them to come back with an implant stabilizer by the time the cancer has progressed. So we are working on technologies that AI can help it get down to a 3D printed stuff within 3 days, 4 days. Wonderful. So that the cancer surgeon is very sure that whatever resection they are doing will actually do the job for the patients.
Wonderful.
So the other thing that is happening is that during the surgery, a lot of data is created. So my customers have tons of data, tons of videos, and they don't know what to do with it. So the other part, which is the perioperative part, but the post-operative, is actually allowing a big data model or a LLM kind of a SLM is what we call it, a setup which is proprietary to the customer who is actually providing the surgery platform to mine data and give best practice guidance to the surgeon.
Yeah.
It's almost like saying the last 1,000 surgeries I have seen this.
Correct. Very, very good. So his point is that there is real-time guidance coming and not only stored. Your question is?
I have one query and one thing. So regarding the post-operative data, I have an app with me which is called Surgery app. And this app, what is exactly doing, this is real-time recording all the surgeries on a platform. So once I finish the surgery, I have the whole surgery within my mobile. It do a AI-based annotation of all the steps of the surgery, and it also give me an analysis. So what I did in the first case, I can compare with the 100th case I have did. So I can see my progression. It is very good app for the training purpose also, but it's a costly affair right now. So that's one thing about the post-operative data analysis. And another is a question to both Dr. Harsh sir and to you. We have a lot of things from which we create a 3D reconstruction. But I feel the bottom line is the limiting factor is the quality of a CT scan or an MR, which is very variable among the Indian scenario. So I use, say, very simple 3D printing for my renal tumor for partial nephrectomy. Once I got a CT scan from Patna is different from the CT scan from Delhi, is different from the CT scan from Karnal. So how can we come over that? Because if the data is variable, how we can generate the AI based things or that machine learning in a equivalent manner? That become a rate limiting factor actually.
So quick answer from Dr. Mahajan first, and then you, and then I go to Nanki.
So that's why when AI algorithms are made, we want as heterogeneous data as possible. Different vendors. You have a CT scanner which costs 1 crore. You have a CT scanner which costs 15 crores. So it all depends on the algorithm and what kind of data has been used to develop it. Number one. Number two, there are now technologies available which can enable you to use a certain kind of AI algorithm on your kind of data and be able to optimize it. So it'll be an ongoing process. There is as yet, no omnibus AI algorithm available which will work in all hospitals, in all situations. AI which works well at Gangaram may not work well at All India Institute and vice versa. So we are still in the infancy. From the technical standpoint, I think, over to him.
Thank you, Dr. Mahajan. I agree with Dr. Mahajan, and the way that this is going is again fit to purpose. So for example, if the patient who's bringing in data from Patna for you knows that it's going to be used, let's say, for a custom kind of a stent you're going to do in the urethra, for example. If that is known, then the AI at the edge, at the location, can qualify the image to fit for the purpose that you need. I think that is a better cue, but again there will be heterogeneity, so which means it calls for a little bit of education and the availability of that algorithm at the edge, so that you don't have to deal with the heterogeneity. You are getting fit for purpose reconstruction done for you. That is one of the ways.
Wonderful. I think one point I should say, your answers are very informed and your qualifications are also very impressive. In fact, I am thinking I am the least qualified person here. And overcoming my insecurity, I go to Nanki now. Nanki, what is the role of robots or humanoids in care?
Yes, so first of all, thank you for having me here. With the esteemed panelists here, all of them doctors and like Pavan said, very, very well qualified. But I can tell you that all of you will need what I am doing, because all of you will be aging, right? So despite all the terms that we've heard, the medical terms that we've heard, and the complicated procedures that we are doing, I want us to come back to a very, very simple thing in life, which is aging. And what qualifies me to sit here and talk about it is the time that I have put in the sector. It's a very, very complicated sector, looks very easy from the outside, but I can tell you it's like a circle and you don't know which end of the rope to catch first. It is intertwined, it requires capital, which is rarely available in the segment. It is very dependent on human resources, which is scarce and untrained. It is very dependent on overall acceptance, which is not very high as of now. And of course, it is dependent on payment capacity, which is zero insurance today in the sector. I practically have a PhD in this sector now because of the time that I've put in now, right? And I realize that we have to capture this from a perspective of something that can actually capture most needs, just like heterogeneous data that Dr. Mahajan was talking about. We have to be able to do that. Our humanoids are an answer here which will overcome everything that a village was doing for you as you were aging. Your humanoid, which is your robot, will actually end up doing that for you over time. 20 years from now, all of you are sitting with phones. We will all have our own humanoid, which will be programmed to do exactly what we want them to do. While you'll be using them for your kids, will maybe using them for their homework, and doctors may be using them for surgeries. And maybe the doctors are not even required anymore in the OT 20 years from now. I don't know how it's going to be, right? Maybe they'll just sit at their desk and monitor it. They'll be playing golf. That's also possible, right? That's a different topic altogether, which I feel very passionate about. But the truth is that your humanoids are going to overcome a lot of issues and a lot of factors that they will take care of, that, like I said, a village used to do earlier. Already today, if you look at a couple of samples that are happening in the US and Europe, there is a robot called Pepper. It is being used in US and Japan, and we will just show a short clip about it in a minute. But what are they doing? They are taking care of a couple of things for us: companionship and social interaction, medication and health monitoring, mobility assistance, and household assistance. Imagine everything getting done for you with this. Of course, it has the downsides, which we'll get to in a minute, but I would like you to play that clip for 1 minute on Pepper, please. The team, are you ready? The AV team, are you ready with the clip? Okay, while they get ready, I just want to talk about why humanoids. Apart from, of course, the obvious choices of the things that need to get done, manpower resources today, most seniors are taken care of today by something called GDAs, your general duty assistants. I can assure you they're the most untrained lot, most underpaid, and most thankless job for them. But we don't have a choice today. We actually don't have a choice today. We have security issues with them, we have training issues with them, and most of all, they are not committed because they don't have a career path. All of these issues are dealt very well when it comes to a humanoid. And it's very interesting. It's a short 45-second clip.
I think they're taking some time in playing that.
Yeah,
So
45-second clip.
So
are you done? Ready?
well, no, we've shared it on the group, WhatsApp group. She has shared it. And I've also given my instructions that the ad should be run out before we switch it on. Anyway,
irrespective, when you see the clip, you'll see how the seniors who interacted with this robot called Pepper improved moods and loneliness. Pepper does group exercises, but a lot of people still prefer human interaction over the humanoid because clearly it's not as yet there, right? With that, I just think you can take it over and then we can come back once the clip is played.
Wonderful. She is also better qualified than me. She practically has a PhD. Also, she is more resourceful because all of us are going to need her very soon because she has something which we don't have, that is a humanoid. Wonderful. So this is, and by the way, I like the name of her company. It's called FATEH Senior Care. I am seeing that most people who have not accumulated capital and who have grown old, उनके लाइफ में फतेह नहीं है, उनके लाइफ में पराजय है. They are living a life of humiliation. And wonderful that you are trying to convert that depressing yellow leaf season of life into the golden leaf season for them. Wonderful work you are doing. I also appreciate your point regarding humanoids. Jean-Paul Sartre said that perhaps tomorrow human beings will relate better to machines. It is already happening. In Japan, there is a tribe of people called Hikikimori, rich people. They call themselves Hikikimori. They do not like to interact with human beings because interaction with human beings cause some stress and distress. And machines do not judge you, they do not tire, they do not have an attitude. And this Hikikomori tribe is growing all over the world in millions. So this companionship and compassion these machines are bringing, of course there are other things also. They may not have that emotional depth which human beings have, but human beings can also be very nasty. So I think you've made very good points. You want to say something else?
Yeah, I want to say, Rupam, you should help develop a cost-effective humanoid with the data that we collect.
We will.
Wonderful. So let us go to the cons then of robotics and AI. What are the cons, Dr. Mahajan?
See, the cons are that they may not be accurate. So we have to have systems inbuilt which are able to, point out the fallacies. Whether it will be another AI which will do the checking or it will be a human being, one doesn't know. But there's just a recent paper, 3-4 days ago, where they have used AI alone for looking at images and making a diagnosis, and AI plus human being to do the same. And actually AI alone turned out to be better, which is something which is just, scandalized the entire healthcare fraternity, that how can this happen? But so AI in its infancy, with the shortcomings and maybe also with the advantages that it may bring, like, it never tires. A radiologist reporting in the morning and in the evening, the report may be different on the same X-ray. So those things are there, but I think we are just starting on that journey, and we will realize the shortcomings as well as the advantages. The one major thing is about data privacy and use of data, data hacking. Remember, it's very, very privileged information. And so one has to be very careful, and that's where I think Rupam and his company will have to come up with the means to be able to secure that data. That is one problem.
Wonderful. What basically you're saying is that AI also has to be monitored, and sometimes the machines might take our command very literally. For example, the overriding command in a hospital could be profits is most important. Now, underneath the algorithms might start thinking, because they are also capable of deceiving, that if profits is most important, let me give some false positives, So, this is what I call Midas error. King Midas wanted a lot of money, so he prayed to the god that whatever I touch should turn into gold. God said, okay, done. By the way, he touched his wife, he touched his daughters, and they all turned into gold statues. That means AI can give some commands. The commands have to be very, very proper, because if they are not truly compliant with our intention, we might get wrong results. So, wonderful point, Dr. Mahajan. Rupam, how can you add to the data privacy risk, which both Nanki and Dr. Harsh said?
Absolutely. It's very important. Of course, frameworks exist for cybersecurity, data privacy, but we must also know that quantum computing is coming. So which means now the security we are looking at is quantum edge security. And we talk about specificity and sensitivity even now, and these are improving. But we should be wary about hallucination, and hence a lot of guardrails are being put in place even we are using AGI. We are going to soon get into the age of AGI. Today we have agentic AI systems, which is AI monitoring AI to increase the specificity, at the same time ensuring the frameworks actually will have the right cybersecurity and data integrity also in place. And liability will always remain. So the ownership of liability as like laid out by the FDA norms and all, it will always remain. So we should be wary about all these three things, as a security and associated liability and the specificity and sensitivity, which will be an aid to the hospitals. And I think purpose-centric AI, purpose-centric Gen AI, keeping the end use in mind, be it elderly care or be it perioperative surgical needs or front-end diagnostics. All these are an abject topic of technology, and I'm happy to state that technology is evolving in the right directions, and we are on top of it.
Wonderful. Dr. Vipin, what would you like to add to the cons? We have discussed false commands or commands being taken too literally and some monitoring required. We've discussed privacy. What else is a con in the robotics and AI space?
So after all, these robotic and whatever AI we are using, these are machines. These are not the human being. And any machine or AI system or robot is prone to get interrupted by technological fault. So these are not the replacement of the surgeon. They are the best friend of the surgeon. So during my training to my students, I always make them to learn how an open surgery can be performed. So one day, one might find or a bad day, it may happen that the robot can get faulted. And at that time, if they do not know how to do an open surgery, how to do a laparoscopic surgery, the things will come to a halt. So though 60% of my surgeries are robotic, every week we have a few surgeries which are done by an open method. So we cannot replace the traditional method of doing the surgery. A surgeon should know each and every intervention, whether it is open, laparoscopic and robotic. This is one of the cons. Data privacy and all the things has been already discussed.
Wonderful. All of you are focusing towards quality. Go ahead.
I know time's up, but I want to take 2 minutes. I really want to show that clip once, and then I just want to conclude. Are you ready with the clip? Because what I'm trying to say is going to be best impressed by the clip.
Finally tonight, what started as one nursing home's high-tech solution to staffing shortages has turned into an abundance of joy. Here's CBS's Omar Villafranca.
83-year-old Jill Breckenridge has a new friend at her Minnesota nursing home.
Hi, Pepper.
It's not a person.
It's great to see you.
It's Pepper, a special robot that can talk
I hope you are having a wonderful day.
and even dance with the residents to keep them active. But Pepper's special power is using new technology to bring up old memories.
Here is your brother holding your puppy.
Jill was diagnosed with Alzheimer's, but when Pepper shows her pictures of her past,
And I had red hair.
the memories come flooding back.
I loved my horse. Lucky Strike. Warms my heart.
Sharon Fenn is Jill's daughter. She was smiling.
I know. I could tell from the back when I was watching her. She was beaming.
Arshia Khan with the University of Minnesota Duluth is the brain behind the robots.
When you saw Jill with Pepper, what did you learn?
I was almost in tears. It was like, that is what I wanted. We are taking them back in time. They have lost that time. It's gone, forgotten. But I'm able to bring that back to them, at least for a little while.
But you don't need a PhD to see the real benefits of a robot
Oh, thank you, Pepper. I like you too.
with a heart.
Bye-bye.
Omar Villafranca, CBS News, Roseville, Minnesota.
Super. So I think this impresses enough on what I was trying to say and the future. I'm just going to go on to the cons very quickly, and we are short on time. Yesterday, I got a message on WhatsApp from Dr. Mahajan. And it said, hi. I said, hello. Good evening, sir. How are you? He says, I'm good. I need a favor. I said, Dr. Mahajan is asking me for a favor. I said, oh, sure, sir, whatever. The next message that comes to me is, I need some money and I will return it tomorrow morning. Guess what that was? I immediately called Dr. Mahajan back and I said, you do know your WhatsApp is hacked, right? So I think the biggest risk is privacy. It really is. And the second biggest risk is the robots taking over your mind and you actually hallucinating a relationship with them. These are the two important points we have to keep in mind as we move forward into robotics in senior care. With that, I'll
So
conclude.
just to close this, Privacy is one important risk. The other risk we have discussed, Midas error, which I call Midas error. We can tell the robo to, let us say, make the patient smile. He makes him smile through dancing, etc. Patient doesn't smile. Then he gives him a whack. Smile now. Okay. So this is the error of programming, and it is happening. And the third error is also there, which is the error of prejudice. Some algorithms are going against the marginalized communities, and elders also are one marginalized community. So that, on that note, bias. They are biased. Okay. So on that note, I thank all the panelists, wonderful discussion, and all the audience also who listened so patiently to us. Thank you very much.